to the Home of Medicine podcast, a podcast in association with the European Federation of Internal Medicine. My name is Dr. Amie Burbridge, and today I am joined by, in fact, one of my very first guests on the podcast, Dr. Stephen Montgomery Laird. Hi, Steve.
Hi, Amie. How's life?
Same old. I wish I could say something was really interesting, but nothing really to add, apart from the fact I'm painting my hallway and apparently choosing wrong colours. So I've got 10 litres of this blue paint that my husband has told me he hates. Anyway.
That's marriage for you.
That's quite. Okay, so we are going to talk about a case today, and Steve, you are going to put me on the spot.
I am, as usual. I think this is my favourite part of these podcasts, is that we get to terrorise you. Okay, so one of our first cases within my hospital of this diagnosis was a 40-year-old gentleman who presented after seeking help in multiple different healthcare situations. He went to his GP, he went to GUM, and then he finally presented to the A&E department at our hospital, of which he presented with a painful rash in the groin, which had multiple different facets to it. It was a very red erythematous rash, but it also had lesions within this rash. There was also lesions on different parts of his body. And I'm going to stop there, Amie.
Okay. 40-year-old man presented to multiple healthcare settings. He had a painful rash in his groin, which was also present throughout the rest of his body. I guess the first question is, how long has the rash been there for?
So it's a very good question. The rash had been, the primary rash had been there for 12 days. And the primary rash was a little bit more distinct than what the secondary rash was. And I guess that goes on to medical terminology and how we define rash. And especially when we're talking to patients about what they see as a rash, what do we really mean as a rash? Well, I would have said in medical terms, the first rash that presented, lumps and bumps in normal terms. In lay terms, they were lumps and bumps. We would probably say lesions if we were going to describe them properly. They were actually little papules to start off with, and then they turned a little bit more vesicular, and then there was an erythematous base within the second rash, within the second kind of coming of the rash.
Was this rash dermatomal? So was it in one particular area of the body following a dermatome?
So it wasn't at all. The first rash, which were the papules, which then turned into larger papules, all at the same time. All of these lesions were of the same age, and they weren't cropped necessarily. Weren't dermatomal.
Okay, and the reason I was asking that is because she mentioned vesicular, and as soon as I think of a vesicle, I think, okay, is this shingles? Is this herpes varicella zoster or chickenpox? If somebody hasn't had chickenpox when they were little, they could potentially get it when they're a little bit older. Although 12 days seems quite a long time to have that rash. So you said it was painful. Is it itchy?
It's not itchy, no.
Okay. Do you know, dermatology is not my strong point. I don't know whether I do have a strong point.
That's why we're doing this podcast. It's not many people's strong who come to learn.
Yeah, I have to say, and it's like when you're given a rash, what are the important things to ask about? So I guess it is, can it be related to a trigger? So any exposure to any, was an allergic stimulant, any new medication, any recent viral infection, any new medication from over the counter, any changes in washing powder? Was there anything like that?
If this gentleman had presented to us when it was more maculopapular and actually it just started as papular, really, then I would go down the drug eruption, the contact dermatitis route. You're absolutely right. Has this gentleman wore new pants which have got some kind of chemical that they've been washed in? We had a lot of problems with that around about 8 years ago from Chinese sofas that were causing a lot of contact dermatitis. So the way I've described the rash was when the gentleman first came in and described it, it was very well circumscribed. So the area, the lesions were all very, very similar, and They were slightly raised. They were painful, like we said. They weren't itchy, and they were on both sides of the body. In the inside of the groin, and I guess this is another important thing, isn't it? What areas have they affected? Have they affected just the cutaneous layer? Have they affected the mucocutaneous layers, of which they did as well? So it actually went up from the last third of his legs into his genital area, onto his testicles, and onto the penis shaft, and onto the glands of the penis. Plus, there were 3 or 4 lesions which were scattered around different parts of the body, which were similar, and again of similar age, similar size. One on his arm, one on his forehead, which was relatively difficult to actually see because I think this one was healing, and one on his face.
Okay, was there any on his palms and his soles?
No, so palms were spared, and mouth was spared as well.
Okay. Now, the reason I ask that is I'm retrieving things from somewhere in my brain, and palmar pustular rashes can happen in disseminated gonorrhea, potentially. So no, that's wrong, isn't it? Is that right? Is that wrong?
Syphilis is one of the common times in which we'll see palmar rashes, and then of course we have some more unusual psoriasis types where you get pustular psoriasis, which you can get on the hands. But again, this came up really quickly. And the other thing is he had a temperature. So I didn't give you that bit of information. So he had fever ongoing as well.
Okay. So aside from the rash, he had a fever. And how long had the fever been there for?
The fever had been there subjectively for around about 3 days after the rash had appeared. Or that's what he felt anyway.
And was the fever there continuously, or did he feel like he was getting, temperature spikes in the fever?
He felt like he was getting temperature spikes. He noticed them more so on the nighttime than anything else. What was dominantly causing him problems was the secondary problem, which was the redness that was now surrounding these lesions. These lesions, of which some now, at the time which I saw him, days after he hadn't got the help that he required, were becoming necrotic.
Oh, okay. So why was the red area around the lesion causing him problems? Was that because it was really painful?
It was painful, it was hot, and it caused his penis to be remarkably swollen and edematous as well, leading to problems passing urine.
So I guess what you could say is, could this be a secondary infection on top of the rash? Could this be streptococcal or a staphylococcal infection that's actually infected the skin as well as the rash, like as a secondary problem? Is that a possibility?
It's not a possibility. I think it's an absolute. That's exactly that's what we had with this gentleman. Right. There were 2 different problems which were very distinctive, ones taking a history that came up at different times and presented in 2 completely different ways. So one was a problem of the other being infected.
Right. Okay. When you do have skin infections like that, does it tend to be your staphylococcus and your streptococcus bacteria that are the causes of those infections?
Yeah, so you've got the normal breakdown of the skin, and then your commensals on the skin usually cause problems. We do see in lower extremities that you will get coliforms, because no matter how much we'd like to think that we wash really well, we do get some of our poop bugs down onto our normal skin biome, and ulcers, especially nice juicy ulcers, can get colonized like that. But up in that area, and the guy wasn't a bedbound patient. He was a fully active 40-year-old working gentleman with no past medical history. I'm trying to feed you a little bit more here.
Yeah.
No drugs, no over-the-counter drugs, a little bit of alcohol use. So he only had around about 12 units a week. He didn't smoke, and he didn't do IV drugs, which is another thing that you'd want to think of if you're thinking, is this disseminated group A strep, for example, especially with our IV drug user population, with bumps and bumps coming up for weird and wonderful reasons. Okay. So non-immunocompromised is probably the most important part of his past medical history of what we knew.
Okay. So would another possible diagnosis here be HIV seroconversion?
For the redness and unusual rashes, usually in your kind of T-zone area with your seborrheic dermatitis or a florid flush, but with fevers, it could be. Okay. but not with these very well-defined lesions. I'm going to go back to the word lesion because
Okay.
we're medical here.
Okay. Now, the other thing you mentioned, it was in his groin, and there was a particular problem with the swelling. Do you often get fungal infections penetrate the skin? Could he have had thrush or candida that could have affected this, not just the bacteria?
I don't think so in the way in which it presented. Sometimes you
Right.
can get other fungal infections like histoplasmosis, which cause lumpy manifestations and then can ulcerate out, especially on the peripheries. But this guy didn't have a travel history. I'm going to throw that in there as well. No travel history,
Okay.
no kind of contact with any bat droppings where people can sometimes get these from on traveling. Nothing that we knew of, and nothing that should disseminate out like a cutaneous cryptococcus. That would be a potential, but not in this gentleman.
Okay. So you said he had a fever and a rash. So now I want to think about sort of other constitutional symptoms then. So what was his appetite like?
Reduced considerably.
Okay. Had he lost any weight?
Not much. Probably a little bit of fluid weight loss just from not eating and drinking as much over the last 4 or 5 days, for just feeling generally sick and ran down.
Okay. And what about sweats at night? Was he waking up at night with the bed sort of drenched in sweat?
No, he absolutely wasn't.
Okay. Did he have a headache?
No, but he did feel tired and like there was a fullness to his head with an element of subjective confusion, but completely it's a bit of a red herring that I'm throwing you there, Amie.
Okay.
He was a GCS 15 out of 15, completely with it. It was just subjective, thought that he was a bit slower in thought, and I think that's just purely because he was quite unwell.
Yeah, absolutely. Because when you do feel unwell, your brain doesn't work as effectively as normal, does it? Had anybody commented to him that he was confused or had any, seemed a little bit different to normal?
No, but the reason that I mentioned the confusion and slowness of thought is because he stopped working around about 3 days before that because he just wasn't up to it anymore.
Right. Okay. And what sort of work did he do?
He did a office-based job.
Okay.
Yeah, no contact with any animals. Nothing that I would throw that one your way if there was that.
And any family history of any medical problems?
None that we know of.
Okay, so going back to the infective symptoms then, I guess to complete that section, any diarrhea and vomiting?
No diarrhea and vomiting at all.
Okay. Any urinary symptoms, any painful urination?
No painful urination, but he was struggling just because of the swelling of the skin on the penis, so that at the penis end exit of the urethra, that was a problem, but that was it.
So had he developed a phimosis?
No, he hadn't. It was literally because his penis was so swollen. It was an extrinsic compression, really, of the urethra. Yeah. Gosh. But he was able to do it, just had to put a lot more pressure behind it.
Okay. Okie doke. Any chest pain?
Nope.
Shortness of breath?
No shortness of breath.
No. Any cough?
No. Yes, but he did. But again, red herring. It's because he was slightly unwell with a cough, with a slight viral respiratory disease around about 7 days before that. Absolutely nothing to do with this presentation. Just didn't want to lie to you. Should have said no.
Well, are you sure? Okay.
I'm sure.
Okay, so he had a bit of a cough. Did he bring any phlegm up, any blood?
No, none at all.
No. Okay. Any abdominal pain?
No.
No. Okay. Any swollen joints?
No.
No. Okay. And
there's something else there. There is a big thing that made us worried very quickly, and you were saying swollen something.
Oh.
And his testicles were okay before we can't talk about testicles, apart from the abnormal swelling of the skin.
Right. Okay. Swollen. Lips, gums. Any allergic reaction?
No, none at all.
No.
That's right, Amie. He did have swollen lymph nodes.
Yes, he did, didn't it? Oh gosh.
He did. He had significant swollen lymph nodes in the groin, so very, very regional, very swollen lymph nodes, big volumes.
Were they painful lymph nodes?
No.
Non-painful lymph nodes.
But as a non-medical person, he was extremely aware of them.
Right. Okay. So there must have, because I often don't ask a patient if they felt their lymph nodes because you don't feel them, do you? But if you are noticing yourself, what about axillary lymph nodes?
There wasn't anything palpable there, no.
Okay. To be honest though, it's not something I'm very good at examining for axillary lymph nodes. I do it, but it's challenging. Okay. Did he have any muscle ache and pain, any tenderness?
He didn't.
Okay. I guess now you've mentioned his temperature, so let's have a look at the examination. What was his blood pressure like in his?
Well, we're not going to do examination. Amie,
Oh.
we've known each other for many a year. What part of this history am I going to get upset about if you haven't asked me about? And we've done travel already.
Oh my God, sexual history.
Right.
Yeah, okay. Apologies. Yeah, that was a genuine, I forgot. Okay. Sexual history, of course.
What do you want to know about it?
So I guess I want to know. So sexual history, is he having sex?
He is having sex, and he's having sex with men only.
Okay.
So he's a man, and he has sex with men. He had sex around about 3 weeks before he became unwell, before he presented with lesions.
And is it a usual partner or is it multiple partners?
It's a new one-off partner.
Okay. And did they use protection?
No.
Okay. And before this episode, how long ago before that had he had sex with somebody?
That I don't know actually. That we probably asked him, but that I don't remember because I didn't focus on it. Sorry.
Okay, no, it means it's probably not important then, I guess. Okay, do I need to ask anything else in the sexual history then at this point?
You could ask whether he's anally receptive, orally receptive, or whether he's not receptive whatsoever. But on this occasion, it doesn't matter because we're going to do a thorough examination. But
Okay.
we'll come to a reason why that kind of question is sometimes important.
Yeah. Okay. So, are you happy for me to ask about the examination?
I am.
Okay. So, just I guess his general observations, please.
So he was febrile on admission. He had a fever of 38.6.
Gosh.
So not a big, massive, swooping, horrible viral fever that you might expect with something like chickenpox or measles, in those 39s and 40s, but still good going.
Yeah.
He was from the end of the bed. He looked well enough, but he looked tired and worn out.
Okay.
So I think that's always pretty important. He was aware of his situation. He was orientated in person, place, and time. And general examination, there was the lesions that I've mentioned already. No describing hand features that I can think of, and no discerning hand features that I can think of. He was tachycardic at 115 beats per minute. His respiratory rate was normal. It was 14, but he was quite anxious as well. He was quite actually, in fact, very anxious. A lot of people had seen him about this since by the time we got to see him. Chest clear, heart sounds normal, abdomen soft, non-tender, with no with no organomegaly. He did have lymphadenopathy that was in the groin, and then he had multiple lesions all over his testicles, penis, the top of his penis going into kind of the crease folds of his legs, down into his legs. Nothing on his anus, and nothing in his rectum, which was examined. The lesions which I've mentioned peripherally, and then he had this swollen skin, which was extremely erythematous and painful and hot. We marked with a pen, and it literally went from legs to above his abdomen.
Okay. So I guess when I'm thinking about it now from an acute physician perspective, or like a general physician perspective, I've got a gentleman in front of me who looks unwell. He's tachycardic. He's pyrexial. So what did you say his blood pressure was?
Oh, I didn't give you that.
No,
but his blood pressure all the way through was holding. Actually, he's not a non-hypertensive. He's not hypotensive, and it was roughly about 140/90.
Okay, so at the moment, then we're not thinking of sepsis, although he is still tachycardic with that high temperature, and he said he looks quite unwell. So I guess from an acute perspective, the first thing I want to do is do that A to E approach. You said he's sitting up and chatting, does he need any oxygen? I'm going to get some cannulas into him. I want to give him some intravenous fluids. Let's try and bring that heart rate down. But I also need to do some blood tests, making sure I did blood cultures as well full blood count, U&Es, LFTs. Let's look at his CRP, virology, potentially. Am I looking for herpes? I could also do some serology, I guess, maybe EBV, CMV, HIV test. I really want to do a HIV test because he's had unprotected sex. I know it was 3 weeks ago, so it's quite early in that seroconversion process. But if he's had unprotected sex 3 weeks ago, he may have had it before, so he could be at risk of having HIV. And whenever I do a HIV test, I always look for other sexually transmitted diseases, such as syphilis. So I would like to look for that as well when I'm doing my blood test. But I think, first of all, I really need to stabilise him with the fluids. And actually, the skin is very red, very edematous, very painful. It looks cellulitic. So I'm going to give some intravenous antibiotics as well. I'm probably going to give some flucloxacillin if he's not allergic to it. And if it's particularly bad, I might add in some clindamycin. I'm not sure what your thoughts are of that. Would that seem reasonable?
Yeah, I think that seems reasonable. If you're really, really worried, because what we do with clindamycin is we use that to turn off toxins for group A streps and sometimes for the PVL Staph aureus. But we only use that for a short course and then carry on with our backbone Fluclox. So what we did, we actually just give high dose Fluclox, and I did have a colleague who talked me into giving some ciprofloxacin as well for some gram-negative cover, just because it was in the groin area. But we soon decided to stop that.
Okay. So I guess then when I'm happy that I've brought his temperature down, he said he's in a lot of pain, so I think it's really important. And often we do forget about pain control. Is actually trying to get on top of his pain, which will also probably bring his heart rate down a little bit. Other investigations, I mean, we need to do a chest X-ray. We need to find out if there's anything on his chest. We could do a throat swab to see if there's any infections in the back of his throat. If there is any serous fluid coming from the lesions, we could send a sample of that off potentially to see if anything grows from that. Urine sample to see if there's any urine infection. I'm beginning to, I mean, the only other thing with the pyrexia, the subtle confusion and meningitis, okay, it's a real stretch, but I guess that's something that I'd want at the back of my mind, even if it wasn't at the forefront. So whenever I'm thinking about diagnoses and I'm not sure, as like in this situation, there's so much going on, I'm not entirely sure what it is. I'd like to think at the top, what is the most serious thing this patient could be suffering from? Sepsis. So I'm going to manage that. I'm going to rule in or rule that out. So meningitis, do I need to do a lumbar puncture on this gentleman? Do I need to do a CT scan if he's confused? Potentially. And then think about, checking his lactate, doing a VBG, and then thinking about what else this could be. Is it chickenpox? Is it disseminated herpes? Is it syphilis? Is it a drug reaction? Is it eczema? Is it erythema multiforme? Is it Stevens-Johnson's? I guess it's very difficult to know without really, I guess, looking at it, what it could be. Could it be insect bites? Over the summer, I've had so many people in with so many insect bites.
Yeah, and we've had chronic scabies which are presented slightly like this. We've had Norwegian scabies which have been horrible, but again, not in this working 40-year-old non-immunocompromised, non-institutionalized person. And this is why history is so important, isn't it? And then going back to examinations, I am going to challenge you on a few of those. Do we need a chest X-ray? We've got a focal source of what's going to be infection, and this is essentially a cellulitic groin, a secondary bacterial infection with a significant cellulitic groin. There's enough there to say that's why the temperatures are. Confusion, meningitis, unusual to get unless it's significant ongoing meningitis, late stage. We don't usually see confusion. Encephalitis, we get worried. So are we worried about encephalitis? And like I said, going back to GCS 15 out of 15, no focal neurology, a little bit of confusion, which is actually very, very subjective. Objective, none at all. Don't need to go anywhere near him with a lumbar puncture.
No, absolutely not. And often I'll just think about it and then I'll completely rule it out. But I think when we are talking about clinical reasoning, and particularly when we've got trainees with us, it's to say things like, right, I'm going to think about a lumbar puncture. These are the reasons why I don't need to do it. Because often we are very said, no, we don't need to do that. But then we don't actually say why we don't need to do it.
Yeah, so, and I think if you're in a realm and if you rang me up as the microbiologist on call and said, I just do not know what's going on, if they've got a fever and they've got these weird vague symptoms, I'd say just do as many tests as you possibly can and go for the most serious first. You know,
absolutely.
you don't want to find out 3 days after the. I remember a horrible time that I had at a smaller hospital where someone passed away very quickly, a very young person who had, you know, after they passed away within hours, and they were there with somebody else. This was a person in the waiting room waiting with a family member, and we had to admit it very quickly, and it was purely because she had meningoencephalitis from Neisseria meningitidis, and no one knew anything about it because she'd had an ear infection for 4 days, and because she was so worried about the person she was bringing in, she left herself. So yeah, absolutely, the most serious things are serious. However, I do want to go back a couple of steps now, if that's all right, Amy. I'm just direct you towards what we did, and that's all of the things that you did, absolutely fine, and definitely reasonable things to think about. However, we have had a massive push recently on certain high consequence infectious diseases which have come through into the country, and we've had a big push on infection control. So people at the door of most of our trusts that we work on, and most of the trusts in the UK now, will have a screening question for certain things. Have you got a rash of unknown etiology? You know, have you got a fever? Have you been to Africa? Have you been to Western Africa? Have you been with anybody who's had monkeypox?
Yeah. Right. Do you know, it's now you mention that, it's one of those things that until you're told about it, you don't really think about it because it's not at the forefront of your mind. But you're absolutely right. Now you said it, it's like, okay, that rash, the fever, general malaise, monkeypox. Okay.
So before, whilst you're doing all your examinations, taking your bloods, and maybe sending the person out of the department towards an X-ray department for a chest X-ray, which might or might not be.
They don't need.
Then we have to think about the infection control aspect. Okay. So this person was brought in very, very well. It was very well done by all of the staff involved on that night shift, and put into the designated room next to the Donnan and Doffen room that we had for query monkeypox cases. And because they were we knew they were a contact of somebody who'd had monkeypox 2 weeks before, that we knew this guy was right up there with, you know, high risk possibility. So we did all of our infection prevention control, put out appropriate PPE on, did all of our swabbing very, very quickly, and got it off to the reference labs for the PCR tests that will give us 2 results. They will give us an orthopox test, whether or not that's detected, which is the family which monkeypox sits in, and then they will give us a specific PCR for monkeypox detected as well. Sometimes we get both of those being positive. Sometimes we just get the orthopox detection on there and not the monkeypox detection. But we will take that definite with this guy's history.
Okay, so you send off. So for any query monkeypox patient, then. What investigations then do we need to do to confirm the diagnosis?
So just specifically to confirm the diagnosis, if they've got lesions, especially if they're able to pop those lesions, which is very, very difficult, and that's another clue to this being monkeypox. They're very jelly-like, rubbery lesions. They look like they're going to be full of pus and really, really easy to pop, but they're quite thick, and if you rub something over them, they're very, very hard to pop. Unlike a staph kind of infection, a folliculitis, where you can pop them like very easy, like a zit. So
a zit. I haven't heard that word for years.
Is that an Americanism? I think it is. I think it's a 1980s Americanism.
I think it's a something off Saved by the Bell or something. Yeah.
So a swab in viral transport media, we would ask for, so a specific swab over the lesion should be enough to get enough viral DNA for us to be able to do a PCR. If the person is highly suspected and there's no obvious lesions there, then back of the mouth throat swab will do. And sometimes if people have presented very later on and they're confused and we think, hold on, we know this is one of our monkeypoxes, people have been doing blood tests as well, blood PCR.
Right, okay. So it's to try and pop that lesion then, to try and get some of the fluid or the exudate out of that and send that off. And if not, oropharyngeal, and if not, blood. Okay, so you've got a couple of options. Okay.
So you don't need to pop it'll be difficult to pop the lesion, so rubbing it over the top should be enough to
really?
And that's why it's a contact high consequence infection. because it comes
Of course.
through onto the cutaneous layer. That's why we can transmit it through contact.
Okay.
And not oropharyngeal, just oral, just the throat swab will do. We
Oh,
don't
really?
need to
Okay.
poke it up the nose at all.
Okay. So, is there any typical abnormalities on a full blood count? So, do they become thrombocytopenic? Do they become lymphopenic? Do they have a raised white cell count? What happens to their full blood count?
Well, that's why this guy gets a little bit more confusing, because he had that secondary bacterial infection. He was massively neutrophilic. So he had a good going, cracking white cell count, cracking CRP. There will be, I think, these trends published very soon with regards to what they've seen as a nation, because we've got a really good cohort in the UK. Now we're heading up to 4,000 people in the UK diagnosed with monkeypox. In our region, can we talk about our region on this podcast?
Yeah, absolutely. I mean, I think it's important to. I mean, we could talk where we are based. We're sort of in the West Midlands, which is like the centre of the United Kingdom. So there's some areas of high deprivation, I guess you could say. There's a lot of poverty, but there's also some quite wealthy areas as well. It's quite a mixed bag, isn't it, really?
It is, the West Midlands, very, very well mixed. And then we've got a number of different cities and urban settings around there, and a number of different types of populations, and extremely eclectic when it comes to cultural backgrounds and what people do as well, from a point of origin or a point of sexuality or a point of actually what they do in their spare time. So monkeypox in globally has been seen, well, in this outbreak, to be mostly associated, especially in the United Kingdom, with men who sleep with men. So I think it's still around about 96% of the positive cases have been men who have slept with men, or men who or non-declared within that group as well. A handful of women, to the last count, it was around about 40 women, and I think only one child still. But that bit of epidemiology hasn't been given back out yet. So within that women group as well, some of those have been transgender, so who have been having sex with men, in either men who sleep with men, gay men, bisexual men, whatever. So that's been happening dominantly at festivals or at sex clubs or at private parties, where there's been usually a group of men who will be having sex on premises. And a lot of that has been seen in London, because it's a high populous area. There's a lot of men who sleep with men within a small geographical area, and there's sex clubs as well, and a lot of festivals there too. So that's kind of the demographic that we've seen now. Because of that, we obviously have to be aware, when we're thinking about case definitions, that population is not more higher risk for catching it per se, but for the individual. So if a gay man never goes and has contact with another gay man, they're never going to catch monkeypox. But we have to be aware that if you're a man who sleeps with men, and you're going to go to a sex club and go into dark rooms and not see guys with other lesions, that is going to increase your risk of catching of monkeypox and other sexually transmitted diseases if you're not using condoms. And that's why. Go for it.
I'm just going to ask a question. This is probably going to sound really silly. Can you contract monkeypox without any visible lesions there? Or is the only way of contracting when there is cutaneous contact?
So there's a thought process that there is an element of respiratory transmission, but that respiratory transmission is very, very low. Hence why we still will wear, as part of our PPE, FFP3s.
Okay.
So if you, and of course, it can cause on some occasions pneumonitis, and we've also had atypical presentations where they've had lesions in the throat presenting as tonsillitis. So if you have shedding and then you're aerosolizing by coughing, then again, that there's a potential. And if you're coughing and you go into a mucous membrane like the eye, you can obviously get it in the eye as well. So there is that theory, and actually, I think it's more than theory. I think we've seen some of those cases now. So yes, there is potential, but the most common by far is cutaneous contact, and close relatively prolonged contact as well. However, you can obviously spread it from one part of your body to the other as well. So what I wouldn't want to do is go scratching my groin full of monkeypox lesions and then putting a contact lens in. That's not something I would personally want to do myself. It's a protected sanctuary area of the eye. If it's not being infected, then your body should be protecting that. But if you're directly going to inoculate yourself in, then there's going to be problems there as well.
With this gentleman then, how did you manage him? Because I know that the management for monkeypox is quite supportive. So aside from the infection, the bacterial infection, which we've talked about, and antibiotics, from the monkeypox side itself, what can we do?
Okay, so there's a couple of things. So when this infectious disease became a large number in the United Kingdom, we started looking into how we can look after our patients, because yes, you can get cutaneous manifestations, you can get eye problems and lose eyes with endophthalmitis, you can get significant lesions in the rectum, in the mouth, which are extremely painful, causing people significant pain, and then secondary bacterial infections leading to sepsis. But you can also get pneumonitis, and it can be very bad, like chickenpox pneumonitis in adults, and you can get encephalitis. So they have to be monitored until they get better, and they don't necessarily have to be monitored as an inpatient, which we originally thought. When the numbers got too big, then we go into a virtual clinic setting. So most places in the United Kingdom set up very quickly a supportive virtual clinic, of which you would have video contact. There would be information and governance with all of that on a specific NHS secured system, where you can talk to your patients who are actually isolating in the home by themselves, as long as they don't have any family members that have to share communal areas, or pregnant women in the house, or children. So that was part of the isolation category C. If they are unwell and they need support, then they are kept in as an inpatient. And if they need antiretrovirals, antivirals.
Mm-hmm.
If they need antivirals, then they're taken to specific areas in the United Kingdom, which are HCID nominated centres, so high consequence infectious disease nominated centres. London, Sheffield, Liverpool being the dominant ones that have been used, and then there are supporting centres as well, a couple more in London, especially as the biggest numbers were there. Therefore, then they have to be looked after by the local regional centre with ID microvirology support. There are a couple of antiviral treatments. So the old treatment, which is not as favoured, but is supposed to be quite good and does work, but it's more of a third line treatment, would be cidofovir or brincidofovir. So this is a thing that's used to treat CMV infections, for example, treat disseminated adenovirus infections in the immunocompromised.
Mm-hmm.
So we use that, cidofovir being the first type, brincidofovir being the formulation of cidofovir where it's a bit more renally protective. But the main thing that is being used now is a really potent inhibitor of one of the orthopox virus proteins, and that's tecovirimat. So there's only a couple of places that hold stock of tecovirimat, because we've got a very restricted amount of oral and IV. And actually, we've just taken a patient into the hospital, and we've had to keep him in our area and use some of this antiviral, very limited supply. The other thing, so that's as much as you can do for these people. So you're right in supportive pain management and then antivirals. What we can do for as a prophylaxis is what we're doing at the moment. So we've got limited stock of the vaccine that's available. And that was originally being given as a post-exposure prophylaxis and had to be given within the first 4 days, really to stop a development of monkeypox, or within the first 10 days to reduce the development of symptoms. So that would be healthcare workers, family members who are immunocompromised, who had been truly exposed. what we're doing now is we're giving the stocks that we've got, and we're expecting more to come, to those people who are high risk from the epidemiology that we've seen. So again, men who sleep with men who are still having active sex in sex clubs would be top of the list. So yeah, so that's how we're doing it at the moment. We've also found out that the vaccine's quite useful. Well, it is very useful, but it's what we found out is that you can actually reduce the dose and give it intradermally rather than subcutaneously. And now we get a lot more people vaccinated than before. So yeah, so there's a few things that we can do.
Yeah, I mean, if I have a patient who I admit because of monkeypox, are there? I know there are some complications of monkeypox. Obviously, we've talked about cellulitis and the soft tissue infections, myocarditis. I know I've read about that occasionally that can happen. Are there any other complications that I need to look out for in patients with monkeypox?
Yeah, so the eye infection is significant.
Eye infection.
Okay. And like I said before, pneumonitis, encephalitis. Okay. So if I'm doing my virtual clinic and people start to get confused, they come straight back in. And actually, at that point, we would do a lumbar puncture, look for monkeypox virus in the CSF, and have a massive conversation with the UK HCID network on what we actually thought was going on with this patient, and do they need to go to a tertiary centre. Right.
And how did you manage this gentleman's penile swelling?
It actually just got better once we treated the cellulite. It was all cellulitis. So there was no obstruction that we could see. Of course, we fully examined him, made sure he's a young guy. He could have had a torsion. It could have been for any other reason. So we made sure that he didn't have any painful testicles. There could have been obstruction because of the massive lymph nodes as well. But there wasn't. It was fine in the end. It all seemed to be because of significant cellulitis.
Okay. And at any point, would you think about Fournier's gangrene?
Straight away. That's what I thought straight away. That's why we kept him.
Oh, really?
So that's one of the reasons that we kept him in, and that's one of the reasons that we give him a broader cover than just gram-positive.
Okay. Yeah. And what was it about the presentation that made you think it could be Fournier's gangrene?
The area and the significance and the significant pain that he had. It was very much like a necrotizing fasciitis-like pain, where you touched it and he was screaming, and then how quickly the rash had developed. But then it started to settle very, very quickly as well. So we wanted to keep him in overnight. Then we decided to keep him in for 4 days, just until everything settled down.
Yeah. Okay. Well, and of course, thank you.
We always had a surgeon in the background just in case. It's just like necrotizing fasciitis, and it's not going to be a medical cure. It's going to be a surgical debridement, unfortunately. But we agreed that he was just not well enough for that, which was a bold call, and I couldn't have gone one of each way, I guess.
Okay, well, thank you so much for that really interesting case discussion about monkeypox. I mean, I've certainly learned a lot. What I do just want to, I guess, touch on before we finish is we talked about the majority of the cases of monkeypox being in men who have sex with men. And obviously in the press, a lot of the reporting has been around this. And I wanted to know what your thoughts were about that. But also, you said that this man had presented to 3 different medical areas before he got help. And I just wondered what you thought was going on there.
So first question, I guess, my thoughts are that you have to be really, really balanced when you're trying to decide what a case definition for a new infectious disease that a country is not familiar with, that the WHO are not overtly familiar with. This is a disease that was seen in very small communities in Western Africa or in Central Africa, and only on very few occasions have we seen it outside of the African continent. We actually had a couple of cases, 2017, where we had our first taste of monkeypox, but there was only a handful of cases, and in that there was a mixed group. So on this occasion, because it's been dominantly one population or a group which have similar epidemiology. So these are relatively young men. Average age between the range is around about 24 to 45, average age around about 30, 37 years old. Some of them are younger, some of them are older, but dominantly, youngish kind of guys who have a sexual history, who usually have got it from sexual contact. Then you have to be very careful about stigmatizing the population. And it's been done. I keep telling people that we've got to be really, really careful with labeling it onto any type of population when we get a new pandemic or an epidemic occurring. We did it with HIV and AIDS in the 80s, and we don't want to go back to those days where we're calling this a new gay disease. We don't want medical professionals to think, because there's a case definition there, that only gay men are liable to catch this, and missing out on treating women, straight men who are saying that they don't have sex with men. There's too much to dig into there.
Yeah, absolutely.
And it's complex, but I think public health have they have to be very, very responsible with these case definitions. And there was a few of us who were quite upset in the way in which it had been portrayed right at the beginning. However, BASH, the society which looks after sexual infections, HIV, basically the GUM's kind of society, they spoke out and led very nicely on this, and did a lot of education on how people should take a good sexual history and how we shouldn't be stigmatized in certain populations.
Yeah.
What are your thoughts, Amie?
Really similar, actually. I think, initially when I was first starting to listen to the case reports coming out, it felt that it was very much being, I guess, reported as a disease of gay men. And it sort of takes you back to those echoes of 1980s. But you're right. I think the way that things are reported in the press and social media and in some particular newspapers can really skew what you think about things, and also can really skew what society think about things as well. And I was really worried about that initially. But you're right, it did talk around, it did change. But I agree with you, we have to be really careful in the initial stages of a disease that we don't see very often, that is now in our country, like monkeypox, that we don't just label it as a disease of men who have sex with men. Because, like you say, you could be missing out on a huge population of people who are not being diagnosed it. So I think we have to be really careful.
I think the one good thing that it did was highlight that terminology, though, that the men sleeping with men thing is different in some men's eyes from being gay or from being bisexual. Some people will just want to have sex with guys and have no emotional attachment whatsoever, not deem themselves as gay or bisexual. So the fact that changed was quite good. I think they captured a few more people and they would open up to it. I think terminology is very important in medicine. I'm not a fan of people being called that hypertensive over there. It's a man.
I know. Yeah. It's a man with hypertension.
Yeah. Being defined by anything is ridiculous when you're a human, when you're defined by many aspects. So yeah.
It is challenging, isn't it? I can understand why we do it sometimes when you're really busy and there's lots and lots of individuals who you're looking after. We do slip into that, and it is hard sometimes, but we have to. I think if we're aware of it, then we need to definitely try and stop that. Thank you so much.
You mentioned two parts to that, though. So that was
I did. The other question was, why wasn't this picked up earlier?
Going through multiple different settings.
Yeah.
There were numerous reasons that the healthcare system failed slightly. And sometimes it's very hard to talk about what the primary problem actually is over the phone. And sometimes it's patients who don't give the information. Sometimes you're not asking the right questions. Sometimes people have ideas of what it is and they lead you down the wrong path. But there were a number of different issues in this case. There were a couple of things, like the guy having a cough, so he didn't get to go into his primary care setting because of the cough. Until he got tested. By that time, it was the weekend. The weekend kicked in, and then it was bank holiday. There wasn't any staff. It was all of those system failures that we usually see on late presentations. And he only came in. I don't think he would have come in. He only came in because of that secondary bacterial infection.
Yeah. Okay. Yeah, it's interesting, isn't it? I mean, I know we are going down that virtual teleconsultation a lot more now since the pandemic. But actually, in a case like rashes, you can't diagnose a rash. Can you really over the phone?
No.
So I guess it is about being aware of that. You know, if somebody just said they've got a rash, it's about, we need to see the rash then, definitely.
Yeah, you do, and you can do it. You can monitor it very, very, very nicely via video, but sometimes you actually do need to get your hands on a rash to see how it feels and see how it looks a bit closer. The technology is getting better. I'm sure we'll get there. So yeah, that was this gentleman, and he was, and we followed him up in virtual clinic. He was very good with the educational aspect. We've used his case on a couple of things, and we thank him gratefully for sharing a lot anonymously with us.
Yeah, absolutely. I mean, there's definitely some really interesting points there. We've covered a huge amount in this podcast. I hope that everybody who's listened has taken away something new. You know, I think we should all learn something new every day, and I've certainly learned something new from this podcast. So a massive thank you to Dr. Steve Laird for joining me on today's podcast. And I want to thank everybody again for listening. If you've got any questions, don't hesitate to get in touch with me on Twitter at Amie Burbridge, or email me at amie@efimacademy.org. Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.